So much, sir, and a very good morning to one and all of you, and thank you to all the chairpersons for having me here. So today I'll be running briefly through certain advanced imaging in modern day refractive surgery. I know many individual components of the imaging in refractive surgery is going to come into the subsequent talks in this session. So I'll touch upon certain essential areas which are possibly not going to be covered in subsequent talks. So really, why do we need this kind of advanced imaging? The reason is we need better screening criteria. There is obviously a greater emphasis on now understanding the basic biomechanics. We have better procedures, SMILE, and so many other companies coming in with SMILE-like procedures coming in. Nuances in our understanding of cross-linking and combination procedures, and our understanding of ectasia itself is evolving. Earlier, a big step was made with placido disc and scanning slit corneal topography, where it really started giving us a good idea, gave us the need to start looking into the posterior float. Then came the importance of the Bellin-Ambrosio display, where essentially we really started looking at focal disease or a beginning of a focal disease by using the exclusion scans, where the central 3.5 millimeters surrounding the thinnest point was being excluded, and then various other parameters and criteria were developed to differentiate normals versus form thrust and keratoconic patients. These bars kept getting pushed up with various indices, various devices, various scans which kept coming up. But the challenge was that there was only so much that our basic imaging through tomography could take us, wherein while we were nearly at 100% when differentiating normals and keratoconus was concerned, the challenge in terms of normal versus form thrust still remained. Still about 7 to 10% of patients could be missed while differentiating between normal versus form thrust. So then came the role of corneal biomechanics, wherein your air puff devices like the Corvus, where the deformation was being measured, and essentially we were looking at a normal versus a potentially weak cornea by the amount the cornea was getting applanated, the deflection that it was taking, and the time that it was taking for the recovery. All based on all these values, various indices were developed in terms of the amount of deformation amplitude, your inverse concave radius, integrated radius, and new devices like Ambrosio's horizontal relational thickness were also devised. While these are all individual parameters, Vinciguerra and his group brought together a new index called the Corvus Biomechanical Index, where the CBI itself was a component of individual components like the DA ratio, integrated radius, ARTH, and a novel stiffness parameter. Adding to the CBI, also a very important useful tool that the Corvus has is the stress strain index, which also gives us a clear idea about the changes that are biomechanically which are happening in the cornea. It's just one quick example which was earlier published, where a patient with an absolutely normal tomographic scan, pentacam looks perfectly normal, but the CBI was quite abnormal. Biomechanically, the cornea appeared weak as per CBI, and this is the fellow eye of that patient who had frank keratoconus. So similar such examples were brought about where one eye was absolutely normal. So the apparently seemingly normal eye of an eye which has ectasia was what was being defined as form thrust keratoconus. And a few of these cases were definitely being picked up by the Corvus Biomechanical Index, which were being missed out. So this was the first publication on this, where the 12 eyes of unilateral keratoconus with normal tomography but abnormal biomechanics. This was then brought together, integrated with the pentacam itself, where you have indices which are now combining the pentacam and the Corvus and giving us a greater sensitivity in ectasia. So you have artificial intelligence combined with Scheimpflug tomography and the Corvus to give you newer values like the TBI, or the Tomographic Biomechanical Index. Now this TBI essentially combined the values like I mentioned and various indices and gave certain cutoff values. Now, the TBI definitely pushed the limits as far as differentiating between FFKC and normal patients. And as you can see here, both the ROC curves and area under the curves, the amount of cases which were being picked up, the sensitivity and specificity were definitely higher with the TBI than what you saw with the CBI or the BAD-D. This was an extremely important and landmark paper where they compared these three important devices, the BAD-D, CBI, and TBI. And the cohort included 480 normals, 204 keratoconus, 94 very asymmetric ectasia. Now, this 94 is the very important subset. Basically, these are 94 eyes which have ectasia on tomography, but the fellow eye has absolutely no indication of ectasia whatsoever. And when you looked at trying to compare this, now, when it came to differentiating KC from normals or ectasia from normals, or asymmetric ectasia from normals, all the parameters worked well. But the only parameter which helped to differentiate normal from the fellow eye of very asymmetric ectasia was TBI, because you could see BAD-D almost made it look like it was the same. There was no difference. In CBI, while there was some difference, it was a very widely spread out data. But only TBI was able to differentiate between normals and this. So it definitely helped taking the boundaries forward. But then to provide a contrarian view, in the last 3 to 4 years of using this device, we've been seeing multiple cases, and just one case example, where absolutely normal eye, very thick cornea, 600 plus thickness, overall D is normal, CBI is normal, TBI is normal, you would expect that, but this is the fellow eye of the same patient. And so there are obviously still parameters which we are not understanding, not able to detect with the devices available. Possibly a step forward, though we've been talking about this for a long time, is Brilliant microscopy, which again is able to look at the spatial parameters, the viscoelastic parameters of each individual layer and not the cornea or the globe as a whole. So that is something which really is important, where you can differentiate between the strength of the anterior vis-a-vis the middle and posterior stroma, cross-linked versus the non-cross-linked portion of the cornea. And these differences, the Brilliant microscopy was able to elucidate. Hopefully, if a device which is more easily available, if it is developed in the future, would be a great thing. I know epithelial thickness is being covered by Namrata madam in the subsequent talk, so I'll not go into the great details, but definitely epithelial thickness is also becoming important investigative tool in identifying early cases. We all know that the epithelium is a great masking agent and tries to cover up areas where there is a sudden change in curvature or transition, like it is happening in the mid-periphery in corneas or in keratoconic eyes, where it is thinner over the apex and a little thicker over the base. So these are just early indicators of what we could be missing out. For taking a step further, our integration of OCT with topography devices, where and the example of an MS39, where you are able to image not just at the epithelial level, but also at the stromal level, looking at the stromal thickness and stromal pachymetry patterns. And definitely the way forward, because of the masking ability of the epithelium, looking at elevation itself at the level of stroma would give us additional information. Just to conclude, Bowman layer thickness mapping using SD-OCT has also been found to be useful, although not easily available at this level of high resolution, where the early disintegration of the Bowman layer and thinning, which are early signs of keratoconus, can be detected. So a plethora of new investigations are available. Given the time available, it's difficult to go into the depth of each of them, but definitely the way forward, early diagnosis and timely and appropriate interventions are possible. Thank you so much for your kind attention.
Thank you, Dr. Shreyas. It was really a nice compilation of all the investigations possible. If I can ask you a question, not everybody can have everything, of course, so can you name one investigation that must be there in a refractive surgery armamentarium for you to give reasonable decision about the refractive surgery?
I mean, at this point of time, you would have to have a good tomographic device, either like a Pentacam or MS39, if only if it was a little cheaper. But yes, I mean, any good tomographic device would be the basic requirement. Even if you are not able to measure biomechanics and all those things, because they are still very much in the evolving stages, there is a lot of sensitivity issues in each of these individual parameters. So a good tomographic device like a Pentacam would be the most useful or basic prerequisite.
Yeah, so the take home here is that there are a number of investigative equipments possible. What we need to do is not one is going to give you all the information and clearly going to say in suspicious cases whether you should or should not go ahead. So it's a compilation of all the data, including your clinical acumen, to decide whether this person is suitable or not.